Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. Now, this is the podcast version of the past week's written summaries, which this week were brought to you by Ketan Patel, Shannon Marcus, Megan Hilbert, Jonathan Brewer, and Clay Smith. Okay, let's skip straight to the fourth article, titled Efficacy and Safety of Adjunct Medications in Emergency Department Ultrasound-Guided Nerve Blocks. A National Ultrasound-Guided Nerve is the name of the registry, block registry study of the journal Academic Emergency Medicine. Now, I think that we should do more nerve blocks in the emergency department. Not everywhere is really set up for this to be financially viable or really incentivizing emergency physicians to do this. However, all the data seems to really point to that you use less opioids and patients are really happy with this care with really minimal side effects for almost any block. So I think it's a great thing to do. And one thing that you can do to get more bang for your buck out of doing a block is to add an adjuvant. Now, the major upside to having an adjuvant is that your block lasts longer. It doesn't really seem to matter that much which adjuvant you use. However, the two most popular ones are dexamethasone and epinephrine, things that are readily available to us. Now, there's been a whole bunch of data already out there that show that these work, well, really well. However, most of the data, or essentially all the data, is not from the emergency department. And well, I think this is more of a mechanistic thing more than anything. I have no reason to think that this would work better or worse on an emergency department patient. It's still nice to see from an emergency department perspective what people are actually doing. And of course, just to double check that these are effective. Now, this was a registry of about 1,800 different emergency department performed nerve blocks. And so this is a pretty good sample of what's going on out there, at least as a retrospective analysis from, still a spectrum of emergency departments. And what they found was that adjuncts were only used 32% of the time, which I'd say is way underutilized, with dexamethasone being used most of the time for these. And what they found as their primary outcome was that when you added dexamethasone to your block, your odds ratio was 2 for getting a 50 to 100% pain reduction at 1 hour compared to no adjunct. Now, for epinephrine, you just didn't really have that effect there. Epinephrine did not seem to be efficacious, at least at 1 hour, unless you look specifically at the fascia iliaca block, in which case they were both effective. Something that I think is probably a good argument for using more adjunct is that the more experienced the physician was who was doing the block, the more likely they were to use an adjunct. So, be wizened, be like your experienced colleagues, use adjuncts. No more complications, but, better, longer lasting blocks. Now, there's another question that's out there, which is how much dexamethasone do you actually need to use? And unfortunately, the study could not answer that. There was no significant difference between any of the doses between 2 and 10 milligrams. For whatever reason, the odds ratio for 6 milligrams was the highest, but at a huge confidence interval. So, take that for what it's worth. Now, I'm a little bit disappointed with the outcomes that were looked at from this study because pain reduction at 60 minutes is not at all why I'm using an adjunct. However, I'm sure it's just a limitation of the registry. But it's still nice to see that people are using adjuncts, and I think that you should use them too. Dex, not hard to get your hands on. It's a pretty good one. And if you've already gone all the way out of your way to do a block, you might as well get the most bang for your buck. Come on. In a spoonful, in the emergency department, dexamethasone seems to work very well as an adjunct for your nerve blocks. If you like to use epi, I wouldn't stop just from this study, but we didn't see that efficacy at 1 hour, not from this study. However, I don't think they were really looking at the appropriate outcomes for studying adjuncts. And then the fifth and final article, which was titled External Validation of the Revised Lethal Triad Criteria for Appropriate Strategic Decision-Making, out of the Journal of Trauma and Acute Care Surgery. Now, I'm sure if any of you have learned some stuff about trauma, you've probably heard at some point about the lethal triad, which is coagulopathy, an INR over 1.5, hypothermia, which is a temperature less than 35 degrees Celsius, and acidosis, so a pH less than 7.2. This is the classic lethal triad of trauma, which was proposed back in the 1980s. However, it's not been shown to be very useful as a triad. It was initially supposed to be an indication for going for surgery. However, the mortality rates when studied are essentially 100% if you have all three, which is pretty impressive, but it's not really a good indication for surgery if you're guaranteed to die if you have these things. So maybe it's not that useful, but it's interesting, and if you see these, poor prognosis. However, in order to try to make these more useful, people have proposed the revised triad, which, truth be told, is essentially the same thing, just modernized a little bit, changed the criteria a little bit, and made more complicated. So here's the revised criteria. There's the major criterion, which is a fibrin or a fibrinogen degradation product over 90 nanograms per milliliter. And then you've got two minor criteria, which is metabolic acidosis, that sounds familiar, eh? Which is just a base excess less than -3 millimoles per liter, or hypothermia less than 36 degrees Celsius. So you've got a few options here. You can either have the major criteria or you can have both the minor criteria. And this has about an 81% sensitivity and 67% specificity for mortality at 28 days. Now, those kinds of test characteristics make this essentially useless, unfortunately. It's just not going to be a strong enough predictor to say, yes, this patient should go for surgery, should not go for surgery. It's not very helpful. So those were the numbers from the original validation cohort, and now we have it revalidated, which gives us essentially the same numbers. So I'm just not seeing these revised criteria being terribly helpful. This was all studied on a cohort of Japanese trauma patients from 23 institutions in Japan and about 1,200 severely injured people total. So on top of the criteria being what I would say actually less useful than the original, because at least I had like a really bad prognosis from the original, these ones are also, they're just not catchy and it's hard to remember. I'm looking at the fibrinogen, I got to remember what the cutoff was. It's a 90, what are the units? It's too complicated and the test characteristics kind of suck. So I just don't see this ever being useful. However, if this article has just reminded you about the actual original classical lethal triad, then know that if your patient has those things, really bad prognosis. Indeed, even in this study, it had a specificity of 99.8% for mortality at 28 days and a sensitivity of only 3%. So if you've got it, you're pretty much going to die. If you don't got it, doesn't really mean anything at all. In a spoonful, I mean, not that I couldn't remember all of this, but I just don't see it being useful. This was a validation study of the revised lethal triad for trauma, and it just doesn't have useful enough test characteristics to be actually applied in real day life. Okay, that's all we're going to talk about from this past week. Let's do a quick wrap up of everything we covered. From the fourth article, nerve block adjuncts, well, they work, even the emergency department, but mostly it showed that dexamethasone worked, so if that's already your go-to, go for it. If you like epinephrine, don't let this sway you though. And then from the fifth article, the original lethal triad, well, it pretty much guarantees death, so they revised it. And this one, it doesn't really tell you much of anything, especially without a better negative or positive predictive value. Now, if you were hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What did you miss? Well, we talked about the best time to actually give TXA according to some modern studies. And then, can nurses do a POCUS to look at how much is in the bladder before they do a cath? And then finally, ESP blocks for rib fractures. Could you be doing this too? Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.